Can you see my PowerPoint, sir?
Yes, yes, yes. I think we can start. So, good morning, one and all present here. Today's session, day two and session one. So, here we have Dr. Abhinav is there with us. He is from Department of 1G. So, he is going to give the domain knowledge regarding their department, this gynecology. And after that, he's going to tell about us that correlating morphological features of gestational sac and early embryo in predicting fast trimester trimester pregnancy loss. Am I right, Dr. Avinav?
Yes, yes, sir.
It's very difficult to pronounce those words. Okay, for me. So anyway, you'll go light on that one. And at last, how you can also give weightage how the AI can help, not required to tell about the AI. So what is the problem you are facing so that if AI will be introduced, then how it will be helpful to you? Suppose you are going through all the reports, those things, if that can be done very quickly by the AI. So not required to go into the AI because whenever I met all the doctors, they told me that we don't know anything about the AI, so how we can participate in this winter school. The things that I told them to you also, you just give your domain knowledge there on that one because the participant, most of the participant, 90-95 participants are from the CSE background or biotechnology background.
Yes, yes.
So they're going to know about the domain knowledge first. After that, whether it is a clinical data or image data, how we can do something like you are also predicting something, but not by implementing this ML or AI. So how that can be, say, it will be easier for us, or quickly we can predict those things, and accurately we can predict, or you will get some help from the AI, so that it will be easier for you to predict or classify or detect whatever may be. So that part we'll do. And thank you very much, Dr. Abhinav. You are accepting our this to attend this winter school. A request to attend the winter school. So
Yes.
now session is yours. Thank you very much.
Yeah, good morning, everybody. I'm Dr. Abhinav. I'm from the Department of Obstetrics and Gynecology of Kalinga Institute of Medical Sciences. And I'm happy to be a part of this AI integration with healthcare. So I'm going to be talking about the topic correlating the morphological features of gestational sac and early embryo in prediction of first trimester pregnancy loss. So what is an we are discussing a lot about health and anatomy and something which most of us will not be knowing because most of us are from CSC. So let us see what we are discussing today. I'm going to tell you about what is an embryo and a gestational sac and what are the normal ultrasound findings we'll be looking for and what are the measurements we'll be taking, problems encountered, and how can artificial intelligence help us. So embryo is the earliest stage of development in humans seen after fertilization. It is a stage that is before becoming a fetus. And gestational sac is the first visible sign of pregnancy on ultrasound. It is the structure present in the uterus. It contains the embryo and the yolk sac. So, what are the normal findings? When we consider a normal patient with a pregnancy which is intrauterine without any complications, we look for gestational sac diameter, location, shape, and echogenicity. We also look for yolk sac diameter, crown rump length, and fetal cardiac flickering. So, this is an ultrasound image showing the gestational sac diameter measurement. This is a picture taken from an ultrasound machine. The small circle which you can see is the pregnancy in the uterus. This is a gestational sac, and we use something called calipers in ultrasound machines to measure the gestational sac diameter. So gestational sac should look regular, placed eccentrically in the uterus. It can be usually identified at 29 to 35 days of a pregnancy, and the rate of size increase of a gestational sac is 1 millimeter per day. And we look for a presence of yolk sac. Yolk sac is something which is in the gestational sac and which provides nutrition to the embryo. We also look whether it is regular or irregular. We also look for the presence of fetal pole, embryo, and cardiac activity. So this is a gestational sac with a yolk sac inside the gestational sac. Can you see my pointer?
Yes, yes, sir.
Yes, sir.
Yes, yes. So this is the gestational sac, and this is what we call as a yolk sac. And this is the fetus. This yolk sac gives nutrition to the fetus. So we take measurements on ultrasound. We take measurements. This, what we are seeing, this line is gestational sac diameter, and this is yolk sac. So what we take is the mean sac diameter as the first measurement. We measure it in three planes: height, length, and width. It is used for dating. We take three measurements. We take mean of that, and with that we have charts, which we get like how old is the pregnancy, how many days it is, how many weeks. We get it like dating. And what are the abnormal findings which we can see in a gestational sac? It is either empty large sac or discrepancy with the crown rump length. What do I mean by discrepancy is when we measure something called crown rump length and mean sac diameter, they both of those, they correspond to each other. When they correspond to each other, we just know whether the pregnancy is going in a positive way or a negative way. And the second measurement we take is yolk sac diameter. It is the largest inner diameter of a yolk sac. This is the yolk sac, and we take the largest inner diameter of the yolk sac and avoid the echogenic margins. What do I mean by echogenic margins is we call this as echogenicity on ultrasound. So we look for margins, we ignore the echogenic margins, and we take exactly what we need. Crown rump length is the gold standard for dating of a pregnancy. It is a single straight line, head end to caudal end. So this is called head end. This is caudal end. We take measurement like this, so it becomes the crown rump length. And with that, we correspond the days of the pregnancy or weeks of the pregnancy. And abnormal findings is mismatch in the measurement and corresponding days or weeks of the pregnancy. Heart rate is also measured of the pregnancy, which is measured with a mode called M mode. It is called motion mode. We have a motion mode in our ultrasound machines. It senses motion in the echogenic features, and it gives us a heart rate of the fetus. So how do we measure all these with our ultrasound machine? So we have an ultrasound machine. It has something called a probe and a monitor. Ultrasound works with ultrasonic waves, which is beyond our hearing spectrum. Humans cannot hear that ultrasound. It is more than 20,000 hertz. It works like a sonar in this Navy. It emits waves and it receives waves. It processes those and it gives an image like this. It is called an acoustic image because we use sound to produce images, and all the measurements are done by using calipers. There are something called calipers. These small lines are called calipers, and we aim those calipers at what measurements we want, and we take the measurements. So what are the common problems encountered in this ultrasound operation? There is something called observer bias because different operators will have different ideas in their mind, different measurements, the way they use the calipers, what they feel, echogenic margins are different. And it is always the main problem is to find the perfect frame required for the measurement. And with multiple patients and different machines, there is a discrepancy in the standardization and regularization of this measurements. Using of calipers, as I told, everybody will have their different idea from where to where we should measure. And some measurements are being done with images and some are being done with videos. So how can artificial intelligence help us in making this job easier? So till now, what I told is the basics of all the measurements we take. And now I'm going to tell how artificial intelligence will help us. It helps us to reduce observer bias. As I told, there are different operators. To regularize and to make a standard out of it, we can use AI, and we can make a model like from where to where we have to measure. And auto biometry can be done in ultrasound with fixed measuring parameters. And a model should be created to identify the presence of a sac, the location, shape, thickness, and echogenicity. Presence of yolk sac and its diameter, crown rump length, and corresponding parameters of days or weeks of a pregnancy, and fetal cardiac activity. These models can also help us to identify normal and abnormal pregnancies and predict risk in the future. Like the pregnancy is measured in weeks, we measure it from weeks to days. As the pregnancy goes on progressing, the pregnant lady might get some complications like high blood pressure, high sugars. This ultrasound model with AI integration can help us predict the risk of failure and complications along the course of pregnancy. So, what can we do to help AI to make its job easier? We have to decide whether we have to use a static frame or a video format. This is my idea. If we can make a 15 to 30 seconds of footage with 1920 into 1080 pixels of resolution with minimum of 30 frames per second, if we can make it as a standard, I think this could be easier for AI to process. We have to code a simple but effective artificial intelligence model. It should be able to identify basic GSAC morphology, presence of it, echogenicity, and shape. It should be able to measure diameters, crown rump length, yolk sac diameter, and fetal heart rate. It should be able to indicate the risk in percentages. Like interpreting a number is easier than features. Like quantitative is easier than qualitative. It should be able to handle multiple files, multiple patients in short periods of time and reduce the probability of observer bias. It should be done with a simpler software like Ubuntu to code. And yeah, I know I need not tell you guys because everybody is from CSC. They'll know GPUs and CPUs to handle the graphic intensive workloads. And what are the advantages with integration of AI? As I told, it reduces the observer bias and high volume of patients screening could be made easier. Quantitative measurements can be taken instead of qualitative. Numbers are easier to interpret always. And in in cases of a peripheral hospital or a doctor who is staying away from the city, they have less experience and less support. This AI integration can help them to reduce their workload. And what are the limitations for AI? What I feel is video quality and standardization issues are still there because we have different machines. Some work at 720p, some work at 1080. We also have 4K monitors. One video quality standardization is required to make the job easier. And integration with existing ultrasound systems is a very big limitation, which I feel because many ultrasound machines are there which are 10 years old, 15 years old, 20 years old. What is my proposal is if we can standardize the video quality and frame rate, we can take those files, process in a different computer, and get the results. And clinical accuracy is also a question now because clinicians' idea is different from a artificial intelligent idea. And there are also government regulatory approvals if we can use it on a day-to-day basis or not. And to conclude this meeting, I say AI could help with lesser experienced sonographers and parameters measured in the early scans could be helpful. Auto biometry by AI can reduce the time taken for examination of each patient. And standardization of files and clean data should be provided by us to the AI for easier processing. Ability to handle large data sets with minimal errors could be achieved if we can standardize all the files. Software and hardware required should be taken into consideration because at the end of the day, the monetary aspect is a big thing to handle. And the logistic and regulatory approvals from the government and health department should be looked after. And workflow integration should be taken care of because if we can integrate this in peripheral hospitals and small centers, it could be very helpful for helping a patient. And last but not least, we should always keep in our mind but that AI is just a support to us, but not replacement. So I've also mentioned two papers, and I've also given QR codes for you guys. If you can scan them and read them, it will be helpful. This is a Chinese article. They have taken 1,600 patients. They measured all the parameters with human measurements first and artificial intelligence measurements next. And they compared and they got very good results. And they have integrated this into their day-to-day healthcare. This is also a paper from USA, Artificial Intelligence in Medical Ultrasonography. They have also integrated this in their day-to-day activities and patient care. And they have got good results. So that is it for today from me. Thank you.
Thank you, Dr. Abhinav. So one question from my side only. Suppose, Dr. Abhinav, we are going to assign one students, okay, as we have promised to the student for the live internship. Then, if he or she will visit to your hospital with all the document like ethical committee, data approval, everything, then what are the data she has to collect or he has to collect from you? Or whether it will be a 2D or 3D data or video, that image will be there or recordings will be there. What
Yes, sir.
exactly?
What they need to collect from us for processing is 15 to 30 seconds, maximum 1 minute of video file, sir. Maximum 1 minute of video file. And what we need as measurements, we'll make a list of it. If you can create a model out of it, then it is easier, because 1 minute video interpreting by a human takes time. But if we give it to a AI model, it can help it. So you need to have video files from us, sir. We'll just tell video files. We'll give you what to measure, from where to where, how to demarcate the echogenic margins. We call it as echogenic margins, sir, because it is a acoustic image created by sound waves. So it creates something called echogenic margins, from where to where. If we can tell that, if we can code it in a way where to where, it is helpful for us. If you send a student to our hospital, we'll give video files. And
And Dr. Avinam, it requires minimum 200 to 300 videos. And
yes,
definitely in each video, there are so many frames are also there.
yes, yes, sir.
Okay. So that is one challenge. And another thing is there, what are the minimum domain knowledge they require to say, they require to acquire? They have
The
to read
students
before,
from your side,
yeah. Yes, yes, from your side. Because minimum domain knowledge required. Because the
uh, from
only image what he
from
will do. Yeah.
from us, sir, domain knowledge.
Yes, from the student perspective, what are the things they have to read before they are going to reach you to collect the data?
To collect the data, they have to read what is the basics of human reproduction, sir.
Okay.
What is fertilization? What happens after that? What gets created in the uterus? Where does it where is it planted in the uterus? So
Because
what
if you are going to tell the heavy words in front of them, they are
yes, yes,
not going to understand that
yes.
the
We
things.
have
So
to
minimum,
simplify and we have to teach them, sir.
yes, sir.
We can do
Okay.
that, sir.
Thank you. Definitely, Dr. Abhinav, you will get one student who can. I think you are supposed to complete your MD.
Yes,
I
sir.
think
Yes, sir.
yes.
Uh,
So that's
we
why
have 1 more
you.
year, but we can
But
help, sir.
before that one, definitely will try to complete one prototype with the
Yes,
help
sir.
of you. Thank you.
Right
Thank you.
now, we have a machine in our department, sir. It is already AI integrated.
Okay, fine.
It does basic things like measuring these measurements, but it is not up to the mark.
Okay.
Like we are unable to rely on that findings. So
So
we are saying
definitely, last point you have mentioned that is not going to the AI
it is
never
not
can replace the doctors.
yes,
That is
yes, yes.
bogus things. Everybody is telling that one also. So whenever I met to Dr. Swati ma'am of radiology, she also told me the same thing. So AI will replace. No, no, nothing like that. If you are not going to work, then somebody will work because many research works are going on the medical things.
Yes, sir. But advantage of AI is what we cannot see, it can see,
Yeah.
because some ecogenic small small parameters which we cannot see with our eyes, it could be measured by AI.
Definitely. So I think Dr. Puspanjali is there from Taiwan. She can give some suggestions if she wants. Yes, Dr. Puspanjali, if you want to say something.
Hi, good afternoon. Thank you, Dr. Abhinav, for your presentation. Actually, we also work in image data and also clinical data, but not, of course, ultrasound, because the one point you mentioned is actually important. The image we obtain or the data we obtain from ultrasound is probe dependent, and it is dependent on the physician. It's a
Yes,
kind
yes.
of subjective. So that is one issue. That's why we do not actually work on ultrasound. But if there is someone who can give us good quality image, is also a good point for us to work on it. I have one question.
Yes.
Although you mentioned like you'll give the data and the students collecting data should have like some kind of domain knowledge, some background. How about the annotation part? Will you provide them the annotation or you will guide them annotate the data?
We will provide the annotation. We'll give them basic
Oh,
knowledge, like what do we need from that AI and
yes.
what do they have to know, like the basics.
Okay.
why we are doing this,
Yes.
what is the advantage with this, so what is the outcome if something is wrong, something goes wrong, how can they handle. We'll give them basic knowledge and it is helpful, it is easier, like we can simplify and we can teach them.
Okay, then that will be great because main point is like annotation. If
Yeah,
you
yeah.
can give the annotation, then the better the annotation, the better the AI will perform,
Yes, yes.
hopefully. Thank you for
And
your.
I've gone through some this coding and all. I've read about all these GPUs, the power required to do all this graphic intense workload and all. So
Oh
I've
wow,
know
that's
some details.
good. May I know also, do you like does KIMS provide like GPU environment also? Like if we need GPU resources, can we use KIMS resource for the
Yeah, yeah,
implementation
yeah. We
part?
can use KIMS resources because we also have our own department of computer science.
Oh, that's great.
Yeah.
Okay, thank
Satyaranjan sir
you.
will help, can help in that aspect.
Hmm. Okay, okay. Thank you.
Thank you, Dr. Pushpanjali. Yeah, Yatharth, you
Thank you,
have
sir.
some question. Yatharth, yes,
Am I audible?
yes,
Yes,
yes.
yes, yes,
Good
doctor.
morning, Dr. Abhinav.
Yeah,
And
good
I
morning, doctor.
think your presentation covered a lot of great topics. What
Yeah.
I wanted to know was that apart from this imaging, the great thing about AI is whatever data you give it, it can find out patterns. It does
Yes,
not
yes, yes,
necessarily need to be from one specific thing.
yes, yes.
So, what I was thinking with this question in mind is that a lot of the times there needs to be a continuous monitoring of sorts. So, are there, because I'm not really sure, are there like biomedical sensors or certain instruments that can continuously monitor and some things that I can integrate into the AI pipeline that can not only give the health of the embryo and give us the information, but give it, but like give certain biomarkers that indicate if new ultrasounds are needed or we need to like do a new imaging soon because some biomarkers are off. Are there instruments like that? And can we
Yeah,
use that data?
there are no such sensors like that as of now. But what I can give as an example is when I said about the gestational sac. So the rate of increase of size of it is 1 millimeter per day. So if we can integrate this measurement into AI, it can help. But usually we don't do an ultrasound every day for a patient. We just do one ultrasound. If something is wrong, we repeat the ultrasound. What I can suggest is if we can take a large sample size, like 1,000 patients, and if we can compare it with human measurement and artificial intelligence measurement, we can create some kind of patterns and biomedical marker patterns which can predict. I know it can predict in percentages or it can give some red flags. It can sense, like I got your idea, as it can sense patterns. When we study a large sample size, like 500 patients or 1,000 patients, we could create a model.
Okay, so
But it,
I get it. Like the
yeah,
data will have the age, and if the certain patients like are do have a certain disease or a certain condition, and the AI might find a pattern there
yeah,
that we generally tend to ignore or tend to be
yeah, yeah,
biased
yeah.
towards.
I've already included the article in my presentation also. It is from China. They have took 1,600 patients. They measured all these markers by human hand and AI. And they followed all these patients till the end of that pregnancy. And they looked back if they had any complications along the pregnancy. And they measured the accuracy of AI prediction. And they got very good results. And they have integrated that into their healthcare now.
Okay, understood. Thank you.
Yeah.
So, Dr. Boppana, if you have any question, Punappa, sorry. Dr. Punappa, you have any questions? I don't think so. So, yes.
Am I?
Yes, Punappa.
Hello.
Yes, Hector.
Yeah, right. I was just thinking, like, Yatharth was asking if we have a continuous measurement, and
Yes,
Dr. Abhinav rightly pointed out it's on a need based. Some protocols will be there in ultrasound for gestation on a week or a suspect, as he said.
yes, sir.
But whether we can individually, each person is different, so I don't know if we can extrapolate one figure into other. But as again Yatharth pointed out, that pattern we can find out. Say if we can collect one person's image for the 9 months or till delivery, and
Yes,
then compile, as Dr. Abhinav said, 1,000 or 10,000 or across India or across a section of a population, or a what do you call, a feature like South India, North India, that sort of a pattern. If we can generate, maybe we should be able to have close to 90, 99%, if at all.
yes, yes, sir.
It's a wide guess, but it's possible, I guess.
Yeah, it is possible if we can do it for a long period of time, like 1 year, 2 years. If we can take
Yes.
a big
Yeah.
sample size, like 1,000 people minimum.
Yes, but then again, in any given patient, the maximum ultrasound scan which we'll be doing is monthly one or something like that. So
Yeah,
monthly one, and the
monthly one
progress.
also we don't
Yeah,
usually,
I know, I know.
unless it is
Need
required.
based. Yeah,
Yeah,
need based. Yeah. Yes, sir. I think this can be. I think if we can sit and brainstorm, we should be able to reach
yes, yes,
some.
definitely
Try
we.
it out. Anyway, it's an experiment. We can always give it a try and see how things go.
Thank you,
Thanks.
thank you,
Thanks.
thank you, Pranapa. So, Soumya Ranjan, so last question we'll take from you, then only we'll move to Dr. Sankeerthi. Yes,
Good morning,
yes,
sir.
Soumya.
Good morning,
Sir,
Soumya.
I want to ask you are talking about the video which will be compiled taking the pictures. So,
Yes,
like the video is taken at the moment, or it is taken for a while, then compiled to a video. Like if we take one video per day, so it can give error. So why can't we take multiple images per day to compile it to make one picture, which can be compiled throughout the ultrasonic period? So please confirm my doubt. I was having that doubt.
when we examine a patient, what we do is we we get the video on our monitor. All these acoustic waves are processed and it is produced as a video. And we freeze it. We pause the video and we measure it. At which point of the frame should we pause is matters. So that could be observer dependent. It differs from one doctor to another doctor. So we cannot exactly pause the frame at this particular point. That is, it takes time. We get that expertise over time, but it takes time to measure. So if we can integrate this model, when to pause and when to measure, video file could be easier actually. Because when we measure on an ultrasound, we take frames like 300 frames, 400 frames for an examination. The output is in video format. Usually the output comes in 720p and 30 frames per second. Now newer machines are there with higher resolutions and higher frame rates. Pictures can be taken, multiple pictures, but I don't know how they could be compiled into a video. What we can give is video file. Video file is easier to give for developing a model.
Sir, so lastly, I want to ask, like, if you can show a video, we can see now, like, for reference, if possible.
I'll just check. Give me a minute.
Hello.
Yes, yes.
Yes,
Yeah. While you're looking for the picture, I just a thought came to my mind. Usually, the ultrasound picks up a 3D sort of a
Yes,
picture,
yes.
and then
3D
it
is
gives
there.
us a 2D. So
Yeah.
if we can go behind the instrument and if we can extrapolate the 3D pictures or the
Yeah.
3D image, maybe we can, that will be a much more useful data than the 2D image picture which we get.
Yeah. Yeah. That is a good point. But 3D, the instruments which are used for 3D imaging are very, very expensive right now in ultrasound machines.
Okay.
What we usually get is a probe of 2 dimensions. The 2 dimensions probe itself costs around 2 to 4 lakhs.
Right.
Just the probe. When we go for 3D, the cost
Right.
exponentially rises like 8 to 9 lakh per probe.
Right. Yeah.
And yeah.
But when we use the 2D probe,
Hmm.
anyway, it is penetrating length, breadth, and depth. But when we
Yeah.
see the image, it is coming in 2D, isn't it?
No, no.
We can rotate the image, a 3D image, and the ultrasound scan, reconstruction.
Yeah.
So similar thing, if we can go behind the screen and if we can extrapolate the 3D data, maybe, I mean, this is not for you and me as doctors to do.
Yeah.
It's the technicians or the electronics or computer people who can
Yes, yes.
try to snoop into the background and
Yeah.
see if they can extrapolate that data. That's just a suggestion. Thanks.
Yeah. What we can do is, if this is the object, we are measuring with our probe from this direction, we get only these 2 dimensions, the height and width. If we put this probe in this direction, we get one more dimension. With that,
That's exactly what
I
I was
think,
telling. Yeah.
I think we can do it. But in ultrasound, there is something called transvaginal ultrasound. So the other dimension could not be achieved with that. That's the
Got it.
thought
Yeah,
process.
I got it. Yeah.
Sinjoy and Vivek, just start the question quickly, then we'll start the next session.
The video.
Video sir is not, I
Yeah.
think, not able to
I
find
don't
that
have it
one.
on me, but I'm checking on
Yeah.
YouTube now.
I think leave it. Okay, we can see. I think that Dr. Sankeerthi is waiting. So just give the answer of these 2 questions. One question from Sinjoy. Can AI
Can you see
evolve
my
from pattern?
Can you see
Yeah.
my screen?
Yes, 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 yes.
This is how it looks.
And the other structure
This
is
is how the video looks.
fetus with the cardiac activity in the center. So we measure the crown rump length, which is 7 weeks, 6 days. Also, you can see figure.
Have you seen the video?
Yes, yes.
Yes, sir.
Yes, sir. Yes, sir.
Yeah.
If any other question, quickly just ask to Sir Vivek and Sinjoy. If any questions.
Yes,
are
sir.
there.
I have a question.
Yes,
Good
Yes.
morning, sir. Good
Good
morning,
morning.
doctor.
Vivek.
So my question is, what failure modes of pre-processing must be there? So what failure modes of pre-processing are most clinically dangerous in gynecology, which we need to keep in mind while integrating the AI in that?
I didn't get you. Come again, please.
Sir, my question is, there must be some failures in the pre-processing of the images. So what failures are most clinically dangerous in gynecologies, which we need to keep in mind?
Failure of failure of identification of a problem.
Yes, sir.
What do you
Yes,
mean?
sir. No, identification of the pre-processing of the images.
In processing of images.
Yes, sir.
Yeah. In
Which leads to some dangerous incidents.
processing of the images, if we consider dangers of incidents, it is only a problem when we miss something, when we miss some important finding in that ultrasound video while image processing. That is what we have to take care of. So when we are developing a model, when we try to developing a model, what we are doing is we compare the human measurement and AI measurement separately, and we don't leave that image processing alone, like to AI itself. We also look at it, we let the AI look at it, and then we create a model, and we have to look at the accuracy percentage and all after that.
Okay, sir.
Yeah.
Sinjoy, any questions? Yeah, quickly just ask. Yeah.
Yes, sir. I asked if like AI can evolve from pattern recognition, as we have discussed, that
Yeah.
it is about recognizing patterns. So multimodal reasoning, like if we go for endometriosis and PCOS, they both have very similar patterns.
Yes.
So how can AI differentiate between them and give us a personalized result?
Yeah. If we can enter into that model, like if we can enter all the parameters, like we know what to differentiate. What are the features on ultrasound with PCOS and endometriosis? PCOS is actually different from endometriosis.
Yes, sir.
PCOS is something that happens in ovaries first. Endometriosis starts from the uterus, outwards. So we can design models like entering the features separately.
So in later stages, they both show similar symptoms. So in that pattern, how will the diagnosis can
Yeah,
be given from AI?
similarity of symptoms are only the pain which is complained by the patient to the doctor. But when we go to ultrasound, the picture is completely different on endometriosis or PCOS.
Okay, sir.
Yeah,
Thank you, sir.
yeah.
Abhishek, any other question or we'll move? We'll stop here. Abhishek. Okay. So thank you, Dr. Abhinav. So
Yeah.
thank you. Many questions are there. We'll take time. Definitely we'll meet again to discuss more details how we can start. So thank you very much. Now we have Dr. Sankeerthi is there. So good morning, ma'am.
Thank you, sir.
Thank you. Thank you.
Good morning, sir. Am I audible?
So many questions are there. That's why 10 minutes delay. Okay, session.
That's all right.
So welcoming to our this winter school session. And
Thank
now
you.
Dr. Sankeerthi is there also in KIMS, working under Pamela ma'am, I think.
Yes, sir.
Yeah, okay. Thank you. So she is going to present on the topic of smarter screening, the role of AI to interpreting 28 to 32 weeks Doppler studies for a safer pregnancy. Ma'am, session is yours now. Thank you very much for accepting our request to join here.
Thank you, sir. Just want to confirm if my PPT is visible to everyone.
Yes, ma'am.
Yes,
Alright.
ma'am. It's visible.
Namaskar and good morning, everyone. I'm Dr. Sankeerthi from the Department of Obs and Gynae as my colleague Abhinav. So we'll continue the topic on pregnancy, which would maybe be more interesting now, as Abhinav dealt with the first few weeks of life, which is related to the gestational sac and its development. I will be talking more into the later stages of pregnancy when we already have a fetus that is developed and how it could probably help us in continuing a safer pregnancy and helping these mothers and babies reach their endpoint, which is a term gestation. And I would be trying to give an idea about what sort of AI can be used in interpreting these Doppler studies that we usually do between 28 to 32 weeks of gestation. And the goal of today's session is very simple. It's just to discuss about medical challenges and how maybe these challenges could be solved with the help of AI solutions. I would like to thank Dr. Pramila ma'am, our HOD, as she has guided me throughout this presentation. So starting off, what exactly are we trying to do? Why exactly is this topic relevant for this session? So at a whole pregnancy lasts for 42 weeks. That is what we would try and achieve. And there is a period of gestation, which is between 28 to 32 weeks. That is when the mother is between this period of her pregnancy, where inside the uterus during pregnancy, we have two components. One is the fetus or the baby, and the other one is a placenta. So the placenta is a sort of organ that forms during pregnancy, which helps in transporting blood as well as nutrition as well as oxygen to the fetus. So this entire unit, that is what we call the fetoplacental unit, is a very essential part of pregnancy. It indicates the growth of the pregnancy and the growth of the fetus and how well the fetus can actually develop. So this particular period between 28 to 32 weeks is exactly when in certain conditions or certain diseases or in certain complications, there begins a sort of insufficiency in the placenta where maybe some amount of blood is not able to pass to the fetus. And so if we focus our Doppler studies at this particular age, maybe it would be perfect for us to prevent the consequences of this issue. So Doppler can detect insufficiency. It has been done. It is what we are doing, where we do growth scans and fetal Dopplers to identify this issue. But Doppler interpretation, as Abhinav said, with the help of ultrasound, is very operator dependent. It is very subjective and it is inconsistent across machines. Each machine, based on the skill of the observer, based on the machine, the reports may vary. So here maybe AI can help in having this role where it can significantly improve the accuracy, consistency, and maybe even help in prediction so that we can ultimately have a safer pregnancy. Right now, the way obstetrics practices is we try and find an issue and then we give the solution for the issue. So maybe with the help of AI, we can shift to more of a predictive obstetrics where we're already predicting the outcome of the pregnancy, and instead of reacting only at the time of compromise, we can react priorly and maybe give these babies a better chance of survival. So just an introduction for those who are new to Doppler and ultrasound. What exactly is a Doppler? Doppler is an ultrasound technique that helps measure the blood flow in the fetus as well as the placental blood vessels. It uses an ultrasound technique where it measures the change in frequency of the sound waves from the moving red blood cells that are present inside these vessels. And based on these changes, it helps us identify how well the blood is actually circulating between both the fetus and the mother. So there are certain vessels that we take into consideration. Just to name them, just so that you have an idea, one is the middle cerebral artery. Cerebral artery meaning the brain. So it tells us about how the blood flow in the brain of the baby is. Then we have umbilical artery. Umbilical artery is the main connection between the placenta and the fetus. So it gives us an idea about how much total amount of blood or how much pressure is the blood flowing through these vessels to the fetus. Then we have a vessel called as ductus venosus, which is part of the cardiac or the heart circulation of the baby. So it gives us an idea about how exactly the heart is functioning. And we have the uterine artery. Uterine artery, uterus as linked to the mother, how much blood is passing from the mother to the fetus. So by measuring all these things individually, we can kind of identify how much amount of oxygen and nutrients is passing to the fetus, whether the fetus is getting enough of this, and whether there is any insufficiency or any signs of compromise. So it's sort of giving us a non-invasive, continuous insight on how well is the fetus actually, or how well is the baby actually. So just to give you an idea of what exactly are we seeing on these ultrasound pictures when we're doing this, is my cursor visible? All right. So this is the umbilical artery Doppler. So first, once we position the patient and we use the probe, we try and identify the umbilical artery based on these Dopplers, which color is dependent on the flow of the blood. And we try and take a measurement. So this is the graph that is seen. So in this graph, there are multiple things that we try and identify, which I will talk a bit later. But just as a generalized idea, maybe the height of the graph, the pattern of the graph, as well as the height of the peak, the height of the low, all the things are measured, and each measurement of this will give us a different idea on what exactly is going on in the baby. So as this is the umbilical artery Doppler, it tells us how much of the flow is going to the baby and how much resistance or difficulty is it taking in the blood passing to the baby. This is the Doppler of the middle cerebral artery. The middle cerebral artery is part of the brain of the baby, so it plays a very important role in predicting the outcome of the baby. Brain, as we know, is a very important organ. So the moment that our body starts going into compromise, or if the baby feels like it is going into a situation where it's not getting enough of oxygen or it's not getting enough of nutrients, what it will start trying to do is it will start trying to push the blood to the brain, thinking that, okay, at least if the brain is growing and developing, the rest of the body will also go through. So by measuring the values of these Dopplers in the middle cerebral artery, we can kind of predict what the situation of the baby will be, and it will definitely influence the management that we as an obstetrician would take in regard to what we want to do with the pregnancy as further. So it itself could suggest how important the interpretation of these Dopplers actually are. Then here we have the uterine artery Doppler, very similar to the previous images. As you can see, it suggests about how much blood flow is going to the mother. There's a very common condition which you must have heard of called as preeclampsia or hypertension, which is the increase in blood pressure during pregnancy. It is a very common condition which is in the rise now in the general population. And the issue with this preeclampsia or increase in BP with the mother is that it causes a difficulty in flow of blood from the mother to the baby. And when that happens, the baby is no longer able to grow, which means the environment inside the mother is no longer favorable for the baby. And maybe keeping the baby inside for longer in such a situation might lead to the baby dying within the mother itself. So there, this uterine Doppler becomes very important. Nowadays, the Doppler studies in this uterine artery are being studied early in the first few weeks of gestation and trying to correlate them to the later onset and the outcome of the pregnancy, whether any changes in these Dopplers are actually leading to preeclampsia as a complication or leading to the termination of the pregnancy early. So this is also a very important Doppler image that is currently being studied in obstetrics. Then here we have the ductus venosus, which gives us, as I said, a look into the cardiac activity of the baby. So to basically understand what these blood vessels are and what are we trying to study from these blood vessels, you have to imagine the blood vessel as a pipe and the blood as water flowing through the pipe. So the things that would matter would be how hard the resistance that the pipe is giving to the water flow, or what is the diameter of the pipe. Based on the diameter of the pipe, the pressure of the flow will change. So based on the same concept, there are certain things that we try to measure in the ultrasound. So the first one is the systolic by diastolic ratio. In simple terms, it just helps us to identify how easy or how difficult is it for the blood to reach the baby, which means that the higher the number means more resistance. More resistance means less amount of blood flow to the baby. Similarly, we have a pulsatility index, which is how hard the blood has to work to flow through the vessel. We have a resistivity index, which tells us how difficult or easy is it for blood to flow through the vessels, which means if it's more, means more resistance is there, means more amount of pressure is required for the blood to flow through these vessels. And we have a cerebroplacental ratio, which means the amount of blood that is actually reaching the brain of the fetus. So it might sound a little complex and a lot, but this is just to give you a basic idea of what all we are trying to look. And this will help you identify why is it important to look into these things. So based on the findings of these images and based on our interpretations of them, if we feel like the umbilical artery, which was the connection between the placenta and the baby, if the pulsatility index of that is high, then that signifies to us as obstetricians that there is some amount of placental insufficiency. In simple terms, what this means is the placenta is no longer able to contribute to the blood supply of the baby. Now, what would happen if your blood supply is cut off? The baby would definitely not be able to grow any further, and depending on which gestation this actually occurs, it will lead to us having to decide whether we want to end this pregnancy now or we want to continue this pregnancy. As I told you before, a pregnancy lasts for 42 weeks. If nature has made it till 42 weeks, it is because 42 weeks are required for this baby to actually develop as a whole. So if placental insufficiency develops earlier in the pregnancy, it means we would have to terminate the pregnancy earlier, which means that it would definitely impact both the mother and the baby to some extent. The second finding that we usually look for is the middle cerebral artery pulsatility index. What this suggests is a brain sparing effect, which I had explained in the beginning. The body tries to compensate for this missing amount of oxygen that it's not able to get by sending all the oxygen to the brain. So this will tell us that, oh, okay, the fetus is already trying to adapt to a situation inside the uterus where it is not really able to deal with. So it is a change that is occurring, which is telling us, oh, okay, in the future, maybe the fetus might get compromised. Again, becoming a very important part for us to identify. Then we have the cerebroplacental ratio. So each of these findings have certain percentiles and certain values based on the period of gestation that has been studied through years, and they have now given guidelines and standardizations for that. So if this value is lesser than the fifth percentile, that means that the fetus is at risk of hypoxia, as in there is a risk that maybe the baby is not getting enough amount of oxygen. And the DV abnormality, it is something that really helps us identify whether the baby requires an immediate delivery or not. So, identifying whether this flow of blood is going forward motion or backward motion, or there is no flow, will help us identify how immediately do we actually have to take an action, or how immediately do we have to intervene and do something in order to save this baby. So, coming to what exactly are the problems that we as obstetricians or as a sonologist that you would find while using or while trying to do a Doppler? The first one is operator dependency. It is a highly skilled intervention. So, you usually require lots of training to do it. And as Sir and as Abhinav had already spoken, ultrasound is very angle and probe dependent. So if we could maybe find a way where the AI would help correct the format and the angle that is being placed of the probe on the abdomen, maybe it would help us give better and good resolution of these pictures. And variation in angle, if it can help detect the incorrect angle and identify a proper placement of the probe, that would help even those who are not as skilled and not as trained to get a better reading. Then each of these waves that we saw requires a particular tracing in order to identify these values, which I mentioned, like the S by D ratio or the CPR ratio. So if AI can help generate those tracings, that would be beneficial. We already do have an option of an automated tracing in the Dopplers that are already installed in our department, but again, they're not very reliable, and usually people prefer to rely on the manual tracings instead. And data challenges, of course, based on the different machines of ultrasound and based on their different powers, there's very difference in the configurations that is required for these ultrasounds to be done. So how can AI actually help us in this situation, or what do I think maybe AI could help do? One is image quality assurance. As I said, based on the probe, a lot of it, the outcome of the image depends a lot on it. So maybe if there could be guiding mark lines or some sort of identification that, okay, maybe the probe placement is not right, it could help improve the image quality that we have. Second is the automated waveform detection, which is automation tracing instead of manual tracing. Then this is the one which I found the most interesting, predictive fetal surveillance. As I think Yatharth was asking about patterns or talking about patterns, this is something which maybe we could use patterns in and kind of predict the fetal surveillance outcome. We can maybe provide lots of, again, a large sample size, maybe 500 to 1,000 pictures of video formats of ultrasounds, and also provide the same ultrasounds outcome, as in an ultrasound that was done at 28 to 32 weeks and what exactly happened to that baby or to that pregnancy. And then we can try and identify maybe a pattern or something that is not previously recognized by humans in the ultrasound features, and then correspond to, okay, this particular feature has led to this particular outcome. And then by doing larger studies with larger groups and by making it more generalizable, maybe we can get a forecast from the AI, such as, this fetus is at a risk of hypoxia in the next 1 to 2 weeks. There might be a need for emergent delivery. Or, AI predicts that there's a 75% chance of fetal deterioration within the next 7 days. It is not that we would go dependent on these findings of the AI, but definitely in smaller setups or in PHCs or, the smaller clinics that are on the peripheries where they don't really have trained obstetrician, these sort of programs might at least give them a red alert that, oh, okay, it's about time that this pregnancy cannot be handled by me. I should definitely shift this patient to a higher center so that I can save both the mother and baby. So maybe it can help us to shift from, as I said, the reactive obstetrics to a predictive obstetrics. It can also help to predict the growth restriction progression, as in once it onsets into the baby where the baby is not able to grow anymore, it can help us predict, okay, at what rate is this baby going to grow, which could maybe lead us to change our decision on how long do we want to wait before we end this pregnancy. So what is the real life causes or the real world uses where we could use this? One is in rural and remote settings where there's not much facility for skilled and trained personnel to work. So it could definitely help there to be a red alert and to at least guide these doctors who are working in the periphery to help refer them to a higher center. Then busy tertiary centers, for example, in KIMS, where you have a very high patient load. So giving 100% attention and 100% focus to every single Doppler and every single image is humanly impossible. So in such cases, maybe the AI can help in giving us better results, can help us see patients faster, can help us give more accurate results. Research as a whole, definitely standardized waveform extraction, multicentric researches can help provide comparable data sets and increase our knowledge or our ability to do the Doppler. And public health monitoring, we can definitely use this to understand in general what the Doppler situation is in the public, generalized public, not only those who are at high risk. So there would be some amount of ethical and media legal responsibilities that would have to be followed up when we are trying to do such studies. We would have to do prospective trials and external validation, as in we can't just use those who've had a bad outcome. We must make sure we see all sorts of pregnancies, including normal pregnancies, so that we can generalize the data that we have in our population to a larger population group. Along with that, we would have to do continuous monitoring of these programs after we deploy it. It can't just be like, okay, we have launched the program and we just hope it works. We would definitely have to follow through with it and see whether the plan is actually working or not. As Abhinav said, and as Sir also mentioned, that AI cannot replace doctors, but it can definitely assist them. So it can definitely make practice better for both the patient and the doctor. And it can help us to ensure that no mother loses a baby to a preventable cause. Something that could have been prevented doesn't actually occur. So this is an article which summarizes the current use of AI. It is just a multi-study approach where they've defined the processes of obtaining ultrasound images of a lot of different factors, such as the fetus, the fluid inside the uterus, the placenta, and it used a lot of neural networks, machine learning, deep learning models, and tried to assess what exactly could AI help in obstetrics. So maybe going through this would give you a better idea on the technical part of it, which I am a little poor at. And this is another paper which I found where they used deep learning in the artificial intelligence tools in order to identify image analysis. And deep learning, as we know, excels in image recognition. So in this part of Doppler and in this part of ultrasound, I think image recognition plays a very important role. So maybe by using deep learning models, we can definitely improve the outcome of what our pregnancies are. So to conclude, I would like to say that Dopplers at 28 to 32 weeks of gestational age provides a crucial insight into the fetal well-being. And this AI can definitely help enhance the accuracy and predictive power that we have. And it has to be a collaboration. It cannot be a project only by clinicians or only by engineers. It has to be equally done from both the sides. Both the sides need to have some amount of understanding of the subject. So it is not only that the computer engineering students get some domain on their topic, but as doctors as well, we must understand what exactly is capable from the AI part of it and how much can it actually be done. To us, it really seems like, an imagination or like something out of our world, but that is the reality that you all are seeing. So maybe we also need to be trained into some basic aspects of what the computer science can help us, so that we can get better project ideas as well. So together we can create a safer environment for both the mothers and the babies. Thank you so much.
Thank you, Dr. Sankeerthi. So, lot of questions are there. The session was very informative. So, lots of questions are there for you. So, ready for it. So, first I will ask to whether Dr. Sulagna is there. So, Dr. Sulagna, you want to ask something? Want to add something? Are you there?
Oh, yes, sir. Good morning. Thank you, ma'am, for this nice presentation. And it's really informative for us, like from the AI background, because we really don't have any clinical background related to that. But yeah, the things you have mentioned, if we will do, if we'll continue to like collaboration and if we will do something, then yeah, it's a very good lifesaver and for the fetus and also for the mother's hope. The one thing I just want to know maybe actually during my PhD we have work actually for the intracranial stenosis, whether the patient is how much stenosis it is. That part, what we have done, we have used the MRA data and we find out what is the how much narrowness of that one to find out the from the blood pressure actually from that intracranial artery. And here you have also mentioned MCA and other types of artery. Actually, we have also done similar study, but that one we are using MRA image, and we have considered TOF MRA sequence. I think we can also, maybe not the exact thing, but I think some similar idea we can also include in this part of the study. And as you have also mentioned, there are many AI can helpful for like applications can helpful for you. Uh, I think if we will go for the study first, let's to go for the fetal surveillance because it is the first priority to save the
Definitely,
baby. Yeah.
definitely.
So the other things like the probe adjustment and those part, yeah, that can be technical. That can be in future in the long term. It might be helpful. But let's start from the fetal surveillance. And another thing I'd also like to ask you, do you think only image data like from the ultrasound data is sufficient, or do we need to also include some kind of clinical biomarkers for better outcome?
Definitely, we require clinical and history and the other aspects of the mother because in humans, every human is different. Each
Yeah.
pregnancy has its different features. So, definitely, when we consider, like, for example, as an obstetrician, when an ultrasound comes to us, we don't just rely on the image, right?
Yeah.
Along with the image, we
Yes.
see what are the risk factors that this mother has. Based on that also it will change the progress of the pregnancy. So definitely there will be requirement of other biomarkers or other history that is required from the mother, and I'm sure maybe like we can input those also into the
Mhm.
system and generate like a risk score including all of these factors
Okay.
as well. Might be a little intensive though, but I'm sure it
Yeah.
can be done.
But I think that will be very much useful if we go for a bimodal so that we can have image data. We have some other biomarkers so that it can give us a concrete result. Uh,
Definitely.
yeah, I'm think for now from your presentation, I'm just thinking because honestly, I really don't have very less much idea related to that. So just I'm thinking how AI can be helpful for the doctors. So regarding that, and another thing from the probe, like the one you have mentioned from the wave pattern, like you are finding, and also some kind of the pressure pattern we can find. Can we also got like those numerical values? Because as well as we'll give the machine to the image as well as some of the numerical values like you have mentioned, maybe you are getting some pressure value or something. Can we get those values from the image?
Yeah, that is exactly what we see in a Doppler. We see
Mm-hmm.
the waveform, and then the waveforms are converted into a value. That is what I was mentioning as the pulsatility index or
Oh
the
yeah.
cerebroplacental ratio. They all come as a value, like 1.02 or 3.25. They're all numerical values only that we derive from them. Based on those numerical values, we take a decision. So it's not
Oh,
exactly the waveform, but those waveforms do get converted into numerical values.
thank you, ma'am. Actually, your presentation is really very clear, and we can do many things actually from this idea. And thank you very much. Actually,
Thank
I
you
think
so much.
from now up to this moment, I think this is only my input. If we'll do study more, then maybe more questions or many queries will come. Thank you so much,
Definitely.
ma'am. Thank you so
Thank
much,
you so
sir.
much.
So, Dr. Sulagna, thank you. So, Dr. Sulagna is working with Dr. Prasanna in a work. So, we are working on that one, almost completed. So definitely looking forward to work with you. Thank you. So, now next question is from Yatharth. Yes, Yatharth.
Hello, Dr. Sankeerthi. While you
Hi.
were giving your presentation, I was like noticing my thought patterns, and what came up was like a twofold question. First is that uh, if in the first place we do end up finding something wrong, then what are the actual steps we can take to actually save the baby? And that got me thinking for my second question, which was which is actually the best age to take the biomarkers from the baby and take like the best amount of scans and the stage of the embryo where there is the highest chance of actually saving it.
Okay, just to clarify, your questions are one, if we find a bad report, how do we proceed with it? And two, when is the best time to identify these risk factors, right?
Yep. Yes.
Okay. So as I mentioned to ma'am also previously, in obstetrics, everything is case dependent and individualized. You cannot make a generalized statement that, oh, okay, if this is the outcome, then this is what I have to do. It cannot be an equation where A plus B equals C, because you are dealing with a dynamic individual. Both the fetus and the mother is very dynamic situation. So there are many guidelines that help us decide that, okay, based on this situation, what are we supposed to do? So each finding requires an individualized management, which is why I mentioned that maybe we would have to input other factors in order to predict this risk. We cannot just take the ultrasound image. We might have to input other factors such as the mother's BP, or, whether she has developed increased sugar levels in her blood during this pregnancy or not, and whether this is a pregnancy that has been spontaneously conceived or they used some IVF or test tube babies. All of these things will add to your decision on what you want to do next. But definitely one thing is for sure is that if you find a red alert in an ultrasound, you will at least increase your surveillance. If you feel like the mother requires admission and requires frequent monitoring, you can definitely do that. Or if you feel like she requires a higher tertiary care center where they have more bigger facilities to take care of the baby once it's born, you can definitely refer them to that. So it will definitely help us in that situation for sure. And the second question, which you mentioned about what would be the best time to actually identify these things, the reason why 28 to 32 weeks is a good time is because there is something what we call as the period of viability, which means post this period or post this amount of weight of the baby actually has a chance of surviving in the external world, which means that even if we deliver the baby in the NICU, in the incubator with a ventilator, the baby might be able to survive. And also these placental changes, usually based on previous studies, are most prominently seen at this time. But again, as research is progressing and as science is progressing, there are definitely a lot of scans that now people do in the earlier age groups that help us predict earlier things. But this is usually the generalized standard. At 20 to 32 weeks is when we usually do these dopplers, and predicting them at this time is good in the sense you give a better outcome to the pregnancy. I hope it made a little sense.
Very interesting. Thank you.
Yes, thank you, Yatharth. Dr. Punnappa, you want to ask some question?
More than a question, I was just trying to correlate yesterday's class to today's image. Yesterday, one of our speakers was telling like RGB images, because of the noise, it's always converted to a grayscale image. Similarly, if we can capture these ultrasound images and try to correlate these images with the CT images. Of course, I know in pregnant ladies, we are not allowed to do.
Definitely.
Yeah, but the tissue density is the same. The pixels quality in a CT is the same almost. So if we can try to find a relation between this ultrasound image to a CT image in a non-pregnant woman and try to see if there is some correlation between the ultrasound and the images regarding all the features which you have mentioned, maybe this can be workable.
So definitely an interesting idea, sir. But the thing is, these images which I spoke about, the Doppler, it is pertaining only to pregnancy, because all these arteries that we have seen or all the images that we have taken are of the baby while the baby is inside the mother. And definitely during pregnancy, CT is not an option at all because of the radiation exposure. But maybe we can use it in other gynecological conditions, maybe in cases of ovarian tumors or adnexal masses. Maybe there, if we would be able to compare it in someone who is maybe at a high risk and you don't want to put them to radiation exposure, maybe we can try and find images where an ultrasound could be equated to a CT. I am not really sure about that. But in pregnancy, it might be a little difficult to carry out.
I was not trying to say in pregnancy, we do a peripheral vascular Doppler for peripheral vascular disease,
Yes.
Cardiac angio. Again, we use pictures there. We can always compare the CT images of the angio there and compare it with a Doppler. Of course, in peripheral vascular disease, we can do an angio, Doppler, and see if there is some correlation between the vascular, the Doppler and the CT image, CT
Images.
angio. maybe then we can extrapolate the same thing for the Doppler. Of course, this may be too much for you and me as the doctors. Maybe this is food for thought for the computer science experts. If they can extrapolate the data from the ultrasound and try to figure out what is comparison. Because yesterday, one of the speakers was talking about RGB, noise, and converting it to grayscale.
Yes,
Similar
Dr.
thing
Sulak
if we
now.
can do it. That's the thought. Thank you.
Definitely, sir. Thank you, sir.
Thank you. So last question, I think from Soumya. Yes, Soumya Ranjan.
Good morning, ma'am. So I want to ask about the process where you have shown us the Doppler graph in which the color heat map was formed. So what is the process? Like we are using the pulse wave or the color flow to determine that image? Because both the aspects are using the HRF formation. So what are the new techniques we can evolve and use it in with respect to AI? Actually, that's my the question. Like I was finding difficult to interpret your heat map actually. So can you explain it?
Just to clarify, you want to know how are we identifying these vessels, or I'm sorry, I couldn't actually understand
Like
what
ma'am,
your
can
doubt
you
was.
just differentiate between that the pulsed wave and the color flow? Like both are using the pulse repetition frequency to estimate the parameter and using the like image formation. So can you both differentiate between them?
Okay, actually, the mention of color Doppler, which I mentioned in this situation, was just to identify the Atrian wave, based on which direction the blood flows towards the probe or away from the probe. You have a particular color, either blue or red. So, based on that, you can identify the vessel, and then our data that we collect is based on the waveforms. With the as the blood passes through the vessels, these ultrasonic waves go and hit them, and they create, based on the Doppler event, this waveform pattern. So what we're trying to evaluate is not the color Doppler, but the waveform patterns that we're seeing, which gives us a numerical value. I hope it
Yeah,
has
okay, ma'am.
cleared. Yeah.
Yeah, Dr. Abhinav, you want to say something? Yeah.
Yeah, I just want to add that Doppler color, it gets in red and blue. The red indicates oxygenated blood or arterial blood, and blue indicates the venous blood. When we throw Doppler at blood vessels, it looks at the flow. Arteries have pulsatile flow, and venous veins have continuous flow. The pulsatile flow is indicated in red color, and venous flow is indicated in blue color. That is just for our identification whether we are looking at an artery or a vein. That is why we have color in color Doppler. And Doppler is something that generates heat at the tissue level. So we try to use it as less as possible.
Minimal, definitely.
Thank you, Dr. Abhinav. So Ayush, last questions, you can ask otherwise. Yeah.
Good morning, ma'am. Ma'am, I have a question that since for the processing purpose, we'll be collecting the images of the patient, specifically the mother. So the question is that is the permission of the mother for using that data for training is enough, or we need to go through any legal medical procedure before using that data for research and AI?
Definitely, Ms. Ayush, I want to give some answer. So ethical committee is there, fine. So we have to write down the proposal, then ethical committee will pass that one. So what are the information to hide? Okay, whatever information to be public for the research purpose also. Okay, that is a process is there. So according to a project proposal, research proposal only, they are going to give us permission or not, may not give the permission to use those data. Okay, how much data we can use, what are the information should not be there in the, like that only. Now, Dr. Sanskrit can add more things on that.
Yeah,
Because
and
I have two
definitely.
projects are going on. In KIMS, two projects are going on. One is with Pritam Nath and another one is Nikunj Rao. So same process was there. Means ethical committee is there. In front of once in front of Amita Panda ma'am, we have explained our research proposal. Then another time some other persons are there. This chairman was there. So that the process is there. So not that we'll contact to Dr. Sankeerthi and Sankeerthi will copy and this in our pen drive, and give to us and we'll use that. That is not the way actually. So a lot of legal procedures are there. So accordingly only we have to go through those things. We have the presentation, everything. Then only they will decide whether or how much data or what are the data they should give us for the research. Now, Sanskrit, you can add.
Yeah, consent is definitely essential. And as all of these information come under the personal and private information of the patient, so it is definitely important that we go through this in an ethical manner. And as sir said, it is not as, you come to me and you tell me I need the image and I just provide you the image. There will be a lot of scrutiny about this program, as pregnant women come under the category of people who require extra care in terms of research. Pregnant women and children and old age, all of these come under that category. So definitely it will be looked into particularly to see how beneficial is it going to be and how much risk would this research actually cause to the mother. So it's not just that easy. Consent is definitely essential.
Okay, thank you. I think some of you got the result, huh? Definitely.
Thank you, ma'am. Yes, ma'am.
Okay, then I think no questions are there. Thank you, Dr. Sanskrit.
Thank you so
Definitely,
much.
I'll be in touch with you and Pramila ma'am, okay, to take this initiative ahead. So thank you very much. So the session is over now. Next session will be at 12 o'clock by Dr. Sulakna Mahapatra, and the previous resource person yesterday. She has already taken one session. So thank you very much. So now the session is over. Thank you. Thank you.